This is the One Thing Podcast, and I'm your host, Dr. Adam Rindy. The One Thing Podcast brings together leaders in functional and naturopathic medicine to discuss actionable information that may unlock puzzles in the areas of gut health, brain health, metabolism, and longevity. Please note, these episodes do not replace the opinion of your doctor. They are not intended to diagnose or treat any condition. Please discuss this information with your provider and discuss your own unique personal health history before adapting this information. Please subscribe to our episodes so that you can stay on top of the most current information in these areas of medicine.
In this episode, I welcome on an old friend of the podcast, Dr. Lara Briden, a naturopathic physician based in New Zealand who is a world-renowned expert on hormone health and endocrine-related hormone concerns. You can find her at www.larabriden.com. Dr. Briden was on episode number 9 speaking on endometriosis and on episode 38 speaking on androgen dominance. And she comes back on this episode to speak about female hormones after 40, which is the subject of her latest book, The Hormone Repair Manual, Every Woman's Guide to Hormones After 40. It's available on Amazon and other retailers. Dr. Briden is an expert. She is on the member of the Scientific Advisory Council for the Center for Menstrual Cycle and Ovulation Research at the University of British Columbia, among other accolades. In this episode, we dive deeply into female hormones after 40, which Dr. Briden calls the second puberty. We discuss cultural and anthropologic aspects of perimenopause and menopause. We discuss the 4 phases of perimenopause and how in some women it may start earlier than is traditionally thought. We have a deep discussion on progesterone, testosterone, estradiol, and discuss some of the concerns of treatment and how some women may need extra support, especially when it comes to the role of hormones in brain health, metabolic health, and cardiovascular disease. We discuss specifically which women are most likely to benefit from support during this phase of life. As is tradition on the One Thing Podcast, we dedicate each episode to a nonprofit charity. This episode is devoted to Vitamin Angels, who supports providing nutritional supplements to underserved populations. The first 100 plays of this podcast will be given a donation in its honor to this charity. We will donate $100 total to the Vitamin Angels as part of Dr. Briden's appearance on the episode. Thanks again for tuning into the One Thing Podcast.
Dr. Briden, welcome back to the One Thing Podcast. It's great to have you back on with us today.
Hi, Adam. Thanks for having me again.
Yes. Yeah. I'd love to jump into hearing kind of some updates from you. Since we left off, you were last on and we talked about androgen dominance, yes. And I know you've been up to a lot of things since then. So I'd just love to hear kind of an update on your life.
Oh, sure. So I just checked the dates. That was, I don't know when we recorded it, but it came out middle of last year. So that was during the pandemic, I guess, or already into the pandemic. So since then, I have managed to travel to Canada. I don't know if your listeners remember, but I'm Canadian trained ND, but I live in Christchurch, New Zealand. And I did get back to Canada for a few months to visit family, which was not easy. Pandemic international travel is, I don't recommend it. It's hard. Yeah. So, but now I'm back in New Zealand for New Zealand summer.
Great. And something else big happened between now and then, right?
Oh, yeah. And I've released my new book, Hormone Repair Manual, which is a sequel to my first book, Period Repair Manual, and it's for women over 40. So I'd probably say over 35. It's about Hormone Repair Manual. Every Woman's Guide to Healthy Hormones After 40 is about the process of second puberty or perimenopause, which can start as young as 35, all the way through to menopause, which is actually when periods end, and then beyond, of course, into the menopausal periods.
Yeah, I've always appreciated how you've kind of weaved your own life experiences within your books, such as like, being the mother of your stepdaughter and things she's gone through, and then your own experiences, and now you're in a different chapter of your life. I just maybe share a little bit of that.
Sure. Yeah, I shared actually in this book, the second book, I did share a little bit more about my personal life than I did in the first one. As you say, like, I think the mention of my stepdaughter was one of the only things I did in the first one. But in this one, I mentioned that the fact that I'm menopausal myself, or nearly. In January, I think I will graduate to menopause or achieve menopause, which should be 12 months after my final period, unless I get another one. And I do talk a little bit about just some of, some of the symptoms I've had, and just also some of this. I talk a little bit about in chapter 2, what I call the return to girlhood, this kind of cheeky sense of just wanting to shirk duties and be less of a people pleaser, it seems to be pretty universal across cultures, which is interesting. And certainly I had heard that from my patients, decades ago when I was treating them, and I was in my 30s, and they were kind of talking about this. And I think as a young woman, you don't quite believe it until you get there. And then it's like, this is what it is. So there can be a feeling of just not giving a shit anymore about certain things. Sorry, pardon my French, but it's can be quite refreshing. And
sounds liberating.
Yeah, it is.
I read that part in your book, and I was thinking I've heard it described in different ways, but I love the term cheeky, because that encapsulates the whole vibe.
Yeah, exactly.
So, well, the interesting thing, I think that looking at this topic is sort of, there's, as you point out, a very individual experience.
Mm-hmm.
And, I think from a marketing standpoint, like industry would promote that hormones after 40 is something that might be someone should dread, or it's this awful experience, or watch out, you better be ready for it. I think your book sheds some cultural and personal perspectives that's much more holistic and global. And maybe we could start there with just kind of setting a framework for discussion today. Because I titled this talk, as just hormones after 40. It's just kind of like the subtitle of your book, but maybe we can start with just some cultural perspectives.
I want to start with through the lens of evolutionary biology, if that's all right, because that's my first career. I may have mentioned that in previous interviews. I was an evolutionary biologist before I trained as a naturopathic doctor. So I do see a lot of things through that lens. And so there has been this narrative that in modern day, women outlive our ovaries, and therefore menopause is kind of an unnatural state, which is a state of estrogen deficiency, which should be medicalized and treated with estrogen. Now, first of all, I'll just say I'm not against taking estrogen. So that's, just get that out. We can circle back to that. So without, acknowledging that estrogen therapy can be helpful and all of those things, but still debunking the idea that menopause is estrogen deficiency, because from an evolutionary perspective, that is incorrect. And basically, there's another book, which I mentioned in my book, and which has influenced me quite strongly, called The Slow Moon Climbs by historian Susan Batron. I've plugged her book probably 50 times, so hopefully that's helping her sales. But she takes a deep dive into the grandmother hypothesis, and basically builds the argument through several lines of evidence that it's possible that a longer human lifespan, so a longer lifespan for Homo sapiens in general, which includes both men and women, evolved because of beneficial selection pressure on women post-reproduction. So in other words, it might be the case that ovaries can only keep going for 45 years. That's sort of, maybe they do have sort of a expiry date, if you will, or or for whatever reason, we are programmed, it's maybe hardwired that we can't make babies past 45 or 50. But it's pretty clear that even in ancient societies, people did live to 70 or 80, not the majority, because many people were dying of infection and injury. And so the average life expectancy was lower. But the lifespan, the biological lifespan of what a human could reach if he or she were lucky enough to escape all of those common hazards has for a long time been 70 or 80. In fact, maybe for like hundreds of thousands of years, potentially. Well, obviously, we don't have historical records going back that far, but we do have the few modern day hunter-gatherer people like the Hadza. They go through menopause. And interestingly, and we could talk about this, they do not report on average symptoms associated with the transition. They're generally happy about it. Like it's like, and they do talk about that return to girlhood, or this, you stop having babies at 45, 50, and then you do other stuff, right? Like then you've still, and also we know from the research on the Hadza that women in their 50s and 60s, and maybe even into their 70s, are very productive for the group. Like they actually, the statistic is, and I provide a little bit of discussion about this in Hormone Repair Manual, women in their 50s and 60s gather more food per individual than any other demographic. So they're like providing more food for the group than young people or even than older men. So I just feel like we won't spend too much time on this, but there's this whole argument that older women were very important for survival of their descendants, and that's why this was selected for this post-reproductive lifespan. And so from that perspective, it's not a disease state, right? Like how could it be? It can't be a natural thing that we do and that was selected for, and at the same time be a disease state.
Right.
So So from that, and so then there is also this whole other layer of that, which is that it may be a classic case of what's called evolutionary mismatch, this natural transition to post-reproductive. When that intersects with our modern environment, we potentially do get this whole set of symptoms that our ancestors don't get and that the Hadza don't get, for example.
Interesting. Yeah. I mean, it's also, I think I like how, for a lot of women who you point out who, didn't have their own children or what have you, or have been sort of asked, are you going to have more children? Or, there was all this pressure to, sort of have children or choose that path. That stage can also be very liberating when, things have just moved on from there.
True. You stop being asked about whether you're going to have kids or not. Like you're no longer, when society looks at you, you're no longer, are you making babies? The question isn't, are you making babies or why not? It's like, oh, you have a different role in society now. And we all know, actually, just intuitively, that makes sense, right? Like we all personally know women in their 50s and 60s who are getting stuff done, right? Like seriously getting stuff done, like in politics or in, business or even just in a personal sphere. It can be a very productive time. And so women get to just be seen for who they are. Yeah.
I really love hearing that. I think it's so important. And, maybe we could segue into just talking about the outline of the 4 different phases of the menopausal transition, or just kind of hormone changes. And that would be really good to just kind of set that framework.
Sure. So some of these come from the SWAN study, Women Across the Nation, a decade or so ago, but then modified by Professor Geraldine Pryor, who's a reproductive endocrinologist, a scientist in Canada at University of British Columbia at the Center for Menstruation and Ovulation Research, KEBCOR, of which I'm on her scientific advisory board. And so she sort of modified, she added another phase. So I'll talk about she added this phase which she called very early perimenopause, which is it's a normal phase of a normal perimenopause, but it basically what it is, it's the phase when symptoms arise, but periods are still regular. And that's recently been backed up by a new study that just came out confirming that does happen for some women, not all women. I also want to say at the beginning that, like at this point, that not everyone experiences symptoms. So if you have out of 4 women, 1 in 4 experience no symptoms at all, just cruise through with no dramas. 2 out of 4 will experience some mild symptoms, and 1 out of 4 will experience symptoms enough to seek medical help for it. So that just kind of gives a lay of the land. But in terms of the 4 phases, so using Professor Pryor's framework, which is what I put in my book, very early perimenopause. And again, just to differentiate that from early menopause, which is a whole other thing. I'm talking about a normal perimenopause, menopause transition, which can normally start at 30, as young as 35, and which is different than, say, period stopping at 30, which is early menopause, which is another topic, which I do talk about early menopause in the book, but I think we'll leave that to one side for now. So for the normal transition phase, phase 1 is when symptoms start, periods are still regular. And so symptoms, there's a list of 9 symptoms, the majority of which are neurological. So that would include hot flashes, night sweats, increased frequency of migraines or new onset of migraines. Sleep disturbance is a really classic one. Reduced ability to cope with stress overall, and we can talk about physiologically why that happens. Increased risk of anxiety and depression, which is documented in the scientific literature, and that also is documented that reverts to normal, like reverts back to baseline with achieving or graduating to menopause. So it really is this window of time of recalibration, as I discuss in the book, that women are vulnerable to symptoms, but it's not how you're always going to be. And this is one of my key messages too. Like if you're having more migraines and feeling more anxious and not sleeping, and the other thing is cognition, so forgetting things, it's not how you're always going to be. This is, in a healthy state, this would be just a temporary set of symptoms. And then some of the other symptoms are around menstruation, so heavy, sometimes extremely heavy bleeding, unfortunately, more period pain, breast pain. And then the 9th symptom, I might have missed some in there, but the 9th one is metabolic change, so weight gain around the middle, which if we have time, we can get to today. And a lot of them are obviously interrelated. They're all caused by some of the same underlying processes. So sticking with our 4 phases, that's phase 1, symptoms arise, periods still regular. Phase 2 then is about when there starts to be some variation in the cycle length by more than 7 days, counting from day 1 to day 1 of the next. And we're talking now ovulatory natural cycles. So obviously anyone on the pill, being on the pill negates all of this.
Yes.
And then phase 3 is when there's a lot more variation between cycles, like you might start going 60 days or more between periods. And each of these phases can go on for a couple of years. And then phase 4 is where I am personally. I call it the waiting room. So you've had what you suspect, you wonder if it might be your last period, and then you're waiting 12 months to see if that was the last period. And typically that phase goes on for a few years too, because you'll wait 6 months. It's like, oh, there's another period. And then you have to reset and start all over again. And so if they're going to be symptoms with menopause per se, I mean, I use the word menopause in quotes because what I'm describing is actually called perimenopause. Versus menopause, according to Professor Pryor's definition, is actually menopause is the life phase that begins 1 year after the final period. So menopause is after phase 4. But if they're going to be symptoms, most of them are during these perimenopausal years. And that once you're a few years into menopause properly, there are relatively few symptoms, although there can still obviously be things like vaginal dryness or the genital urinary syndrome of menopause, which I don't know if we'll touch on today because there's so much to talk about in the perimenopause transition.
There is. And your book is just loaded with all this information too. So it's whatever we don't cover, there's a lot more to read. So what's really interesting is just to kind of jump back to the first phase. I think that is not talked about quite a bit as like a bridge into this world of perimenopause. I think, most people, the first mention of perimenopause is well into the 40s, like early 40s is usually what's traditionally mentioned. But it's interesting, like you put out the kind of clear message that this should be a change in your usual pattern. Like if you have, since age 13 or so, have a typical pattern where there's, you're following a menstrual cycle pattern, and then you get to this point in your life and then you start to see these changes. That's when that awareness is so key.
Sure. And keep in mind, phase one, actually cycles could still be completely regular. So, and that's where, I guess it's something to mention here, is that's where part of that diagnostic algorithm is obviously to exclude other causes. So it's not like any person in any woman in her early 40s who gets night sweats, it's not guaranteed to be perimenopause. Like, there could be thyroid going on. I talk about thyroid disease in the book, and there's a strong kind of intersection between thyroid and perimenopause. And then obviously there could be something more sinister going on. So like many things, it's a diagnosis of exclusion. So if other explanations for those symptoms have been ruled out and you're left with a midlife, and I know it's kind of shocking to think 35 is midlife, but
yeah.
And then, if you're left with, a woman having symptoms, midlife woman having symptoms, and other causes have been ruled out, then that's perimenopause. And there's no blood test for perimenopause. And there's no urine test for perimenopause. It's the assessment is done by context and by ruling out other explanations. Obviously, and just to say again, there is a blood test for early menopause. We'll just kind of leave that. But so the blood test FSH, as you know, FSH does go very high with menopause, but during perimenopause, it's bouncing all over the place. It can be quite low. Mm-hmm. And so that can make it frustrating. And see what happens is, and why this, I hope my book is helpful to women, is because women, it's so easy to feel like, okay, I'm just going crazy. Like, I don't know what is going on. I'll hear like, I used to be such a good sleeper and now I just can't sleep. And I don't understand what has happened to me. And if you don't know what's going on, then you can definitely be left thinking, this is how I'm always going to be now. And in chapter 1, I give the example of fibromyalgia. The onset of fibromyalgia can essentially be a perimenopause symptom, not in every case, obviously, because other people get fibromyalgia too. But it's important to understand if this is temporary and not a permanent diagnosis. And it's just worth mentioning too, like, obviously these are, as you said, new symptoms. So if someone has had a lifelong history of mental health and depression, it may worsen in their 40s, but it's not caused by perimenopause. It's still like an underlying issue. So hope that's clear.
Yeah. I think it's during those early kind of changes, the first hormone of consideration that usually comes up in the conversation of that's changing is progesterone. It's often talked about, just as sort of like to pay attention to. And I know Dr. Pryor has been really a pioneer in understanding progesterone and understanding the use of progesterone. Maybe we could go into a deep dive into talking about progesterone. I know you write about it a lot.
Yeah.
And I've had, with the majority of my patients, it's something that therapeutic use of progesterone is generally a positive, but there's always like some variables that pop up from now and then. And I'd love to kind of just maybe do like a deeper dive into progesterone as a hormone, like what it is, and kind of go through some discussion.
Yeah. So progesterone is the hormone we make after ovulation. It's a partner to estrogen. We make it after ovulation in every cycle. And obviously then during pregnancy, we make astronomical amounts of progesterone, which is why actually postpartum is largely kind of a progesterone withdrawal state. And it's generally, in most women, progesterone is anxiolytic or calming, and like anxiety reducing, improving mood. In that way, it's quite kind of tranquilizing, they say. And that's why generally can be kind of a more chilled, kind of sleepy feeling in the early luteal phase. But then on the other side of that, in the few days premenstrually, there's a progesterone withdrawal, which is part of premenstrual mood symptoms sometimes. So just to put it in context. And of course, there's no progesterone in any type of hormonal birth control. I do always need to mention that just to clarify, because progestins are very different, and progestins are not calming like progesterone, because no progestin converts to the neurosteroid allopregnolone that progesterone does, right? So progesterone has this profound effect on the brain, largely beneficial, that no progestins have. And in fact, being on hormonal birth control suppresses ovulation, so robs the brain of progesterone. And one thing I'll just mention, because I think it was something you said in your question, but there is a minority of women, about 1 in 20, who do not experience progesterone as tranquilizing. They have a paradoxical reaction. I think it's a lot to do with their GABA receptor in their brain. So we can talk about that. And that can make it tricky for treatment. So these are women who, I see them in my comments on in my blog, and they're like, this is completely wrong. Like, what you're saying about progesterone being calming is completely wrong, because for me, it made me crazy. It's like, yeah, you would feel that way if you're the 1 in 20. You're like, what is everybody else talking about? That is insane. So
yeah,
that's a progesterone, I guess, sensitivity, if you will. There's definitely some individuality in that, but just kind of zooming out a bit, I just feel like I want to talk about this. So with perimenopause, I would argue it is, as you've just said, and what I say in my book, is that especially the very early phase of a normal perimenopause is largely the result of losing progesterone, or a lower dose of a lower amount of progesterone, because of shorter luteal phases and a shift to anovulatory cycles. And that's in large part what kind of destabilizes mood and the stress response and makes periods heavier, because progesterone is a period lightening hormone. But weirdly, and this is where Professor Pryor's work comes in. As you said, she's been a pioneer, but she's also been kind of a standalone. She is she is not the majority of experts. Unfortunately, this attention on progesterone has not been happening. And progesterone is largely the Cinderella hormone. It's just the forgotten hormone. It hasn't been historically talked about. I'd say conventionally, there's very little discussion of progesterone. The role of progesterone, or its absence, in perimenopause is not acknowledged hardly at all. So this is where this is part of the sort of, I guess this is one area in medicine where there has been traditionally kind of a separation between, on the one hand, naturopathic doctors and natural health practitioners, and Geraldine Pryor, even though she's not a natural health practitioner, but sort of in this camp of saying, wait, let's look at progesterone. And actually progesterone is often very helpful for lightening periods and improving mood and promoting sleep and reducing migraines and all these things it can do clinically. And then on the other hand, conventionally, they're like, what are you talking about? Progesterone is bad for mood. And when the conventional narrative that progesterone is bad for mood, this sounds weird, but this is actually what's happened. They are talking about progestins because there's been this confusion in the research. It's a little crazy when you think about it. Literally for decades, a lot of the doctors and even scientists not differentiating between progesterone, which forms a calming, tranquilizing neurosteroid, and progestins, which generally have an anxiety promoting effect on the brain. So kind of melding those two, then the narrative is, well, progesterone causes anxiety. So they really, from the conventional perspective, a lot of the symptoms of perimenopause are attributed to estrogen going lower, which is actually not what's happening in the earliest phases of perimenopause. It does eventually go lower, of course, but in the early phases, estrogen is up to 3 times higher. So this is where I hope my book will succeed at trying to shift this conversation a little bit and bring progesterone into the conversation.
Yeah, I mean, I think it's really shaped my practice for sure, especially understanding how progestins actually, I think in your first book, you talk about how they actually have almost like a testosterone effect in some women.
Yeah.
Or I guess that's that anxiety effect.
Well, actually, testosterone actually reduces anxiety, which is
the progestins.
Progestins. You're right, absolutely spot on. I think we talk about progestins in our androgen episode last year, but depending on which type or what they call generation or which group of progestins, some of them are androgenic, and for that reason, they can impair insulin sensitivity and cause weight gain. Progesterone itself is anti-androgen. In fact, the other thing that's happened since our last conversation is Professor Pryor and I published a scientific paper about progesterone, cyclic progesterone therapy for PCOS, and we're talking about real progesterone now, and its benefits for reducing androgens and improving PCOS potentially. And also there is an androgen kind of dominance component of menopause as well, that if for women who do end up taking estrogen and hopefully progesterone as well, the natural progesterone, can help maintain healthy metabolism, in part by counteracting androgens. So we can go into that a little bit. Yeah.
So that'll be interesting to get into testosterone a little bit, because I think you really talk about that well in this book, about also the metabolic shifts that can happen in perimenopause as it relates to testosterone. Yeah. So I guess the form of progesterone is always debated back and forth, and in some circles will say that if you're taking bioidentical progesterone and you want it to be central acting, meaning work on GABA and CNS calming, then it needs to be sort of an oral capsule versus like a topical. Is that something that you align with?
Yep. So basically it's very simple. Taking progesterone orally means more allopregnanolone, the calming, tranquilizing neurosteroid, is made in the liver. And taking it transdermally or vaginally bypasses that to some extent. I mean, you still get some allopregnanolone being made from progesterone, but so that's why it's just true clinically too. Oral progesterone is more sedating than transdermal or vaginal. And also technically, and just to align with the research, oral progesterone is currently at least perceived to be effective for protecting the uterine lining from estrogen therapy, whereas transdermal is perceived to be not effective for that purpose.
I see.
But transdermal, not to totally poo-poo, like transdermal progesterone can still, I find, still give some clinical relief from like migraines and mood and things like that. And that's a little bit in the controversy too, because progesterone creams, we're talking about now, or transdermal progesterone, is very much seen by prominent members of the medical community anyway to be like, pseudoscience, like not a thing, like there's sort of this real pushback against progesterone cream. We could talk about that a little bit. I think, and yet as a clinician, I think it does work. Like, it's just like, it depends on which research question you're asking about it, right? Like progesterone creams have been tested to see if they can protect the uterine lining from estrogen therapy, and they cannot, at least so far, according to the research. But then that's been taken to mean, therefore they don't do anything. But that doesn't mean they can still help with some symptoms. So
especially like local tissue health and
they help with mood. There's no question they do. Progesterone creams can help with mood. It's less sedating than oral, but
interesting.
But that has been tested, to my knowledge.
Yeah. I'm just a little tangent. I was just thinking while you were talking that wouldn't it be cool and ideal if your first book gets in the hand of a 16-year-old or 14-year-old that's having some struggle with their menstrual cycles, and they learn about their body, and they learn some tools, and then they kind of go about their life, and then maybe some symptoms start arising in their 30s, and they pick up book 2, and like there's just like this life cycle support. I don't know. It just seems like a really one of your messages is to know your body, right?
Yeah. Actually, to be fair, Adam, that has happened a little bit already. I've had some followers who said they had read my first book like 5 or 6 years ago when they were like 32, and now they're 37. It's like, and your new book is right on time because So, because just to put, just to think about generations, like millennials, like some of the older millennials are in perimenopause right now. So like this is, we think of it as this old lady thing, but like it's not. And that's one of the messages in my book. It's like a lot of women are actually quite young, relatively speaking, when you start perimenopause, and that's normal. That's okay. It's, doesn't mean.
Yeah. Okay. Well, testosterone dominance in perimenopause, the first time I heard of that term was from you. And then I started kind of noticing clinically, that how often that arises. Like, maybe could you explain that? Because most people think about androgen dominance or, testosterone dominance as a feature of polycystic ovarian syndrome or something, along those lines. And so how does that scenario arise? And can you talk about some of the symptoms that might appear?
Yeah. So just to, as the beginning, say that both estradiol, our main estrogen, and progesterone have anti-androgen effects. So that's ongoing. And that's actually part of, just to really zoom out, like with menarche, like with the first we have andarchy, so we have the androgens kick in 10, 11-year-old girls. And then of course we use androgens to make estrogen eventually. So androgens kick in all girls go through kind of a temporary PCOS state before they start menstruating. But then the idea is once ovulation kicks in, then they start making more and more estrogen and progesterone, which then have an anti-androgen effect and kind of end that temporary PCOS. That would be kind of at that end. And then as long as we're ovulating or pregnant, then we're going to have lots of the beneficial anti-androgens. And then with in the later phases of perimenopause, well, first we lose progesterone, then we lose, not entirely lose, but then we have lower estrogen. And at the same time, actually, I didn't know this, but androgens do bump up a little bit in our late 40s. So in women anyway. So obviously, as listeners might know, androgens in both sexes slowly decline with age. Like that's their trajectory. That's true in both sexes. But then in perimenopause, we get this just slight bump up, not back to where it was when we were 20 or anything, but just a slight rise from both ovaries and I think adrenal glands to some extent. And then, but the more importantly, what's happening is a relative androgen excess. So as we lose the anti-androgen effects of progesterone and estradiol, then androgens shine through. And what that means, clinically, is weight gain around the middle. So androgens promote insulin resistance to some extent. It depends, right? Like there have to be other risk factors for insulin resistance, but that's where the that's where we get with menopause. Basically, we shift from hourglass body shape to more of a male body shape. And that is actually, I would argue, to some extent unavoidable. So I have said in other interviews, I don't think we need to fight to maintain an hourglass shape. You can't. I think hormone therapy can maybe help to some extent to do that, but it's okay to thicken a little bit around the waist. But that's androgens doing that. And androgens increase cardiovascular risk in menopausal women. There can be little more subtle things like a slight increase in facial hair, not dramatic. Like if there's a dramatic increase in facial hair, then that's something else. But like a slight, a few hairs on the chin, and basically that. So, and that in terms of combating that, in the book I talk a little bit about the value of estrogen and progesterone therapy, but also just simple things like maintaining a healthy level of SHBG. Will your listeners know what that is, or sex hormone binding globulin?
Yeah, I think they will, generally speaking. And then, that section of your book is really good at explaining what's happening there. Yeah.
So SHBG is this protein we make in the liver, and women make tons more of it than men. I think 3 times more or something. And it obviously binds to, it's called sex hormone binding globulin. It binds to estrogen and androgens. And it's stimulated by estrogen. So when our estrogen goes down with menopause, hand in hand, SHBG goes down. And that also liberates more testosterone. You have more free available testosterone because less of it's bound to SHBG. Hopefully that's clear. And so another holistic strategy is to promote a healthy level of SHBG, which you can do actually with phytoestrogens. And like whole foods. And I think that might be where some of the benefit from phytoestrogens comes in especially for perimenopause, menopause. So, I mean, it's possible with SHBG, obviously there's a sweet spot, but in general with menopause, with age, with insulin resistance, with thyroid disease, all of those things result in abnormally low SHBG. So we can try to counterbalance that.
Yeah. I mean, I always share with my patients, male or female, sort of like every decade learning what's happening with your body, or is really important, whether you do something about it or not, just knowing what the changes are so that you can know how to bring balance to that kind of next decade. Because, I think that's really useful because certain strategies like, whether it's the form of exercise you partake in or the macronutrient balance you have as your lifestyle or phytoestrogens, like you mentioned, could help just bring balance. So it's not as an abrupt change.
Sure. Yeah. And of course, there's tons of which you've sort of started the conversation. We could continue like lifestyle changes to ease the transit or to basically make this transition of perimenopause or second puberty to make it as symptom-free as possible. And we could go into some of that if you want.
I mean, I think I'd love to if we have time, but I think the, kind of the hormone of one of the most interesting hormones to most people is like estrogen. So we probably spend a little time about it. And, I think one of the lights you've shined with estrogen too, if we have time, is its connection to mast cells.
Sure.
And that is fascinating.
Yeah. All right. So estrogen is beneficial. Estrogen is a super hormone. It's like, it's amazing, really. I mean, it is my favorite hormone, estradiol, I guess we're speaking about specifically. Men make it too, as you know, like men and kids and everybody. You actually need estradiol inside your cells, which is why we all have this mechanism of making it from androgens inside our cells. That's mostly how men get most of theirs. And that's how after menopause, we will, if we're healthy, still have quite a lot of estradiol inside cells, just the amount that cells need. Mitochondria seriously love estradiol. So it is lots going on with that hormone. But in the perimenopause transition, estradiol goes higher initially, up to 3 times higher, spiking up to 3 times higher, but then dropping down again. So it's a roller coaster on a monthly basis, but a more amplified roller coaster. And some of the symptoms of perimenopause come from the down the roller coaster, that estrogen withdrawal phase of the cycle, that's what triggers hot flushes, or as we say, down under, hot flushes, night sweats, potentially migraines. And then, but when estrogen is high, in some women, depending on your immune system, you can get a mast cell reaction to that. And because estradiol stimulates mast cells to release, and conversely, histamine stimulates the ovaries to make more mast cell, or to make more estrogen. Sorry, histamine stimulates it. So you get this feed forward cycle. And so that can feel really horrible. That high estrogen, high mast cell, high histamine can feel like headaches, breast swelling, hives, irritability, insomnia. That's definitely one of the mechanisms driving some of the symptoms. And I think that colloquially, when people use the term estrogen dominance to describe a set of symptoms, I think they're actually talking about this histamine mast cell reaction to estrogen.
Yeah.
Technically, estrogen dominance can also mean like anovulatory cycles and not making progesterone. As you probably know, I don't use the term estrogen dominance because it's too vague. But so you get this real ups and downs of estradiol, especially in the early phases of perimenopause, all affected by gut microbiome and immune system and all these things that impair, if estrogen clearance is impaired or if the immune system is reacting to estrogen. And so there are lots of ways to try to stabilize some of that. And then eventually, of course, we do proceed through the phases to a lower estrogen, more consistently lower estrogen phase, which is going to be the next 40 years of our life. So it's not a small phase. Mm-hmm. And that is associated. Estrogen doesn't drop to zero. It drops to about 10%. Estradiol drops to about 10% of what we used to make, like 10% of serum levels. And of course, it's the estradiol making it inside our cells from androgens, which we hope is happening. And so that, especially initially, as the tissues are adapting to that, and including in the brain, there is what I call in the book an energy crisis. Because estradiol normally helps the mitochondria to burn glucose for energy. And so when they can also do other things, right? Like they can burn ketones for energy. They can have some metabolic flexibility. Like there's options. And this is a little bit where the evolutionary mismatch comes in, because I think the Hadza and our prehistoric ancestors, when they reduced their ability to turn glucose into energy, that was not a big deal because they didn't have insulin resistance. They were eating a pretty, lean diet as it was. Yeah. They have a metabolic, if you have metabolic flexibility, your cells can just be like, oh, it's fine. I'll use ketones or use glucose when I have it, and kind of go back and forth. But in our modern world, the drop in estradiol is associated with a shift to insulin resistance, made worse if there's other risk factors for insulin resistance. And I think that's where we get the signal from the research that lower estrogen of menopause is associated with a shift to cardiovascular risk and potentially even dementia risk. So just kind of understanding that it's involved a lot about metabolism and using the metabolic superpower of estrogen and being able to compensate for that and or supplement estrogen is helpful. So
yeah, I think it's really been great the last 5 or so years where estrogen's been taken off kind of the most avoided list, kind of that was sort of plugged for many of years with lots of warnings, and now really presented with more balance of all the health benefits of estrogen. And I did not know that mitochondrial connection. That is fascinating.
Yeah, for sure. And also just, I guess, on the topic of estrogen therapy, if we're kind of at that topic a little bit now, we do also understand that modern, well, especially transdermal body identical estradiol, which is what most modern menopausal hormone therapies are now, is safer. Well, it's safer than estrogen in general. Estrogen is safer than thought for a while, since the women's that 2001 Women's Health Initiative got some things wrong, as you probably know. And so there's a reframing, a relook at the evidence, but also the fact that transdermal estrogen is just safer than the old style of Premarin, oral horse estrogens. And then modern hormone therapy often, not always, but often pairs it with body identical real progesterone, which is also a lot safer than progestins. That's where the biggest safety difference comes in. Yeah. And so modern hormone therapy, if that's what it is, body identical estradiol and progesterone, here's just a little factoid for everyone. The breast cancer risk associated with that kind of formula is less than moderate alcohol intake. So one drink a week. Oh, sorry, what am I saying? One drink a day, not one drink. One drink a week is quite low, but one drink a day would be moderate, between 1 to 2 drinks a day, increases the risk of breast cancer more than hormone therapy. So that's kind of puts it in a little bit in perspective. Yeah. And that does also touch on the fact that alcohol is really bad. So right. There's that. Yeah.
Yeah. Yeah. Really fascinating.
Yeah.
So, there'd be a whole other podcast to talk about what to do about all this, but we've highlighted a few things. I would just love to just kind of hear, your general perspective of, treatment, philosophy, or just how to support the body.
Well, a lot of in the book, as you know, I talk about supporting the body through its recalibration. It's like a software update. It is a challenging time. The neurological symptoms make sense when you think about the fact that the brain is having to do things very differently. It's lost the GABA support of progesterone. It's losing the metabolic support of estrogen. It's had to deal with like estrogen spikes and mast cell, activation and like high histamine. So there's a lot going on. So I come in with what I call in the book the basic action plan for brain rewiring, which that's where I start. And then I do also in the book talk about using progesterone or estrogen therapy and certain other supplements. But the basic action plan for the neurological symptoms is all the obvious things. Like I'll just kind of run through them off the top of my head. Like it's not a long list, but it's like, rest, basically like supporting rest and yoga and breathing and getting outside and green exercise and circadian rhythm and everything that's under that banner of just supporting the nervous system. And then I talk about identifying and reversing insulin resistance, because insulin resistance is really bad for the brain, especially during this transition. And that includes building muscle. And as you know, just building muscle is really good for the brain. Moving the body the brain loves that. There's this exercise and muscle stimulates if I've got this right, like the BDNF, the brain-derived neurotrophic factor. So the brain loves movement. Then I talk about alcohol, like maybe quitting alcohol or dramatically reducing it for the sake of the brain, as well as like for the sake of circadian rhythm and the brain, as well as the breast cancer risk, which I just alluded to. So those are kind of my main lifestyle things. And then I come in with a couple of there's other things like, stabilizing your blood sugar, getting more protein so you feel full and stabilized. And then I come in with magnesium and taurine. As you know, my editor, when she was looking at the book, she's like, I think we should just put magnesium and taurine in the water supply for, perimenopausal women. So, well, as you know, magnesium is beneficial for everyone, not just women. I think one of the main reasons magnesium is so helpful, well, it does lots of things, but as you may know, like it reduces glutamate in the brain. So it's calming to the brain, and the mitochondria love it. So the mitochondria are having to undergo this change. So it really, and most of our magnesium is inside cells, inside mitochondria, which is why you can't measure it on a blood test. I just had a patient the other day say, well, can we measure magnesium? Can we test it to see if I need it? It's like, absolutely not. Like you can't, like a blood test doesn't tell you anything about your mitochondria's requirement for magnesium.
Yeah. And both of those nutrients are so important in detoxification too.
True. That's true. Yeah.
And that's the thing about holistic medicine. It's like if you have one therapy that does multiple things that are beneficial, that's by definition holistic.
Yep, for sure.
So I'm sorry, I cut you off. I think you were going to...
No, that's it. No, I think that was my basic action plan for brain rewiring. And then, of course, like just troubleshooting. There's lots of different treatments for different things. And there's a whole section on hormone therapy, which I'm in general pretty supportive of women using hormone therapy, especially if they need it. But I would also make the argument that not everyone needs it. And I think if women are healthy and fine and symptom-free and don't have insulin resistance and don't, be showing risk signs of disease and don't have risk factors for osteoporosis, then I don't think they should be made to feel like they have to take estrogen. Like I feel like actually the pendulum has swung. It keeps swinging back and forth. Like when I started in practice in the 90s, the narrative was take estrogen to protect your heart. And that was very strong. And it was kind of like, if you don't take it, you're being stupid. And then, of course, the Women's Health Initiative study came and then everyone rushed off estrogen. But now we're starting to get this message back again. It's like, if you don't take it, you're being stupid, which is like, I don't like that either. I think it's more beneficial for some women compared to others. And a lot of it, if I was going to really pare it down, and this is oversimplified, but I think estrogen therapy is most beneficial, both in terms of symptoms and long-term reduction of disease risk. It's most beneficial for women with impaired metabolism or insulin resistance, because it helps to mitigate that or compensate for that. Women with a healthy metabolic flexibility, healthy in all ways, I don't think they need estrogen. So I think it varies. Yeah.
Wow, that is really great to know. It's very helpful. So this has been amazing. I just always learn so much from you, and this is our third time doing this.
Yeah.
And each podcast is just like mind blowing to me. So thank you.
Yeah.
Is there any closing thoughts that you'd like to share with us? Or I know your book is available all over the place, but maybe just kind of share about your website. Your website is just chock full of information.
Yeah, I'm easy to find. My blog is larabriden.com. All of my social media is at Lara Briden. And I just try to share health information on Instagram. That's my main approach with my social media. Yeah. And my books are Period Repair Manual and Hormone Repair Manual.
Excellent. Well, thank you so much for your time. And I really enjoy following your journey. And, I'm sure there'll be more to learn in the years to come.
Yeah, great. Thanks for having me.
Thank you. Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from it. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.